Okay, we are going to go on to section 2 of 3. The first section really was a little bit of background in addition to the approach to the PUI. And so, of course, we know some of the PUIs become negative and then some of the PUIs become positive. So what do we do when the PUI actually becomes positive? So remember, this is not a deep dive. It's really scratching the surface because this information is changing so rapidly, but I will try to give you the most relevant, most up-to-date information. So first to start is how sick do we expect these patients to get? I think what most people actually forget is that 81% of patients will have mild cases, meaning most of these patients can actually stay at home and really just do basic supportive care, making sure that they stay hydrated, making sure that they're not engaged in the community and causing further community spread. There are severe cases. The severe cases estimated at about 14%, and then there are the critical cases. So when we talk critical cases, we're talking about individuals that have respiratory failure, shock, or multi-system organ dysfunction, and that is reported to be at about 5%. The overall case fatality rate is estimated to be somewhere between 0.5 and 7. Most people are saying that it averages out to 2.3%. We showed you slides in the first set of lectures that showed you that Oklahoma is actually doing much worse with the mortality rate closer to about 4%. Again, to refresh your memory, the reason we think that Oklahoma is doing much worse is COVID really affects the individuals that are elderly with multiple comorbidities. Based on our prevalence/incidence of individuals having diabetes, hypertension, heart failure, lung disease, and otherwise immunocompromised statuses, it is not surprising that Oklahoma overall fares a little bit worse as far as their case fatality rate is concerned. The other thing that really plays a role in this is our denominator. If you look at how Oklahoma is doing as far as testing in comparison to the rest of the world and even to the rest of the nation, you see that our denominator is a lot smaller than other people's denominators. So you can see, just based on basic math, how our case fatality rate might seem a lot worse because we're not testing as many people as other people are actually testing. Other things that I think are probably important to know is that the median time from symptom onset to ICU transfer is about 12 days. Whether that holds true, or again, if that's just interpretive data based off of information that's being collected, really hard for me to say. And hypoxemic respiratory failure is by far the most common indication for ICU transfer. So things that can actually help you when you're looking at these patients, in addition to monitoring their clinical status, which frankly I believe is to be the most important. And when I say clinical status is how does the patient look when you are observing them? What do the patient's vital signs look like and how much oxygen are they requiring? You can use labs and adjunct to help make you make decisions about, hey, which way is this patient going? This is a protocol that was actually adopted from the University of Washington. And we had also talked about in the first lecture about how there are some labs that help you determine prognosis. And so you can see right here, the basic labs that we get are the CMP, because we're really looking at the transaminases. Some people also say that you can look at albumin. I think the jury's still out in regards to that. CBC with differential. CBC with differential, really you want to focus on the level of lymphopenia that they have because that's what we find as the most startling. Ferritin, remember we talked about a ferritin greater than 300. CRP, we kind of stratify that into low risk and high risk. Low risk 1 to 20, high risk is greater than 48. Fibrinogen level, coagulation parameters, and LDH. And then IL-6, we kind of touched about this on the last section, but IL-6 really ends up playing a role when you start talking about cytokine storm. And so remember, we talk about that biphasic period, and IL-6 at baseline is helpful, somewhat more so helpful when you start going into that cytokine storm and that second part of the biphasic illness, that number can dramatically increase. And so what you see in the ICU is they recommend some labs daily. And then in the acute CLAR-4, or what we call our COVID step down, they're saying, hey, maybe you can actually check these every 3 days, or if the patient's clinically getting worse. What I think is most interesting, if you see the very bottom, it says labs can be discontinued after 10 days as per clinical judgment. You know, why 10 days? We note that people say that if you are going to get worse, usually 10 days is kind of the hallmark of when people really actually start getting worse. So I think that's where that 10 days actually plays into a role. So if you've got a patient in the hospital for 10 days for whatever reason, if they haven't gotten worse by then, you feel like you have a little bit of green light. I caution you again for saying it's complete green light. But again, I think that's where the 10 days actually comes into play here. So I told you the number one reason why patients end up in the ICU and they end up in that 5% critical region or even that 14% severe region is because they end up developing respiratory failure. This is by far the most challenging aspect of COVID-19. These patients have actually developed respiratory failure. Respiratory failure should be guided not by the labs that I just showed you, but really should be guided by clinical judgment. Were they on 0 liters one day and the next day they're on 6 liters? Are they 0 liters and then maybe 2 liters? You know, how quickly are they getting worse? What's the degree of hypoxemia they're having? And remember, don't forget about the happy hypoxic patient or the silent hypoxemic patient. Those patients may still look good, but you still have to have that notion in the back of your mind, like, hey, this needs to be a watcher. This is somebody that I've got to keep a close eye on. And so in the beginning, when all of this COVID stuff came forward, what we realized was, yes, these patients end up having this hypoxia. And the first recommendations that came out that was supported by pretty much every major international society was intubate them. Intubate them immediately. They're requiring greater than 6 liters of oxygen. They need to be intubated. So what we're finding as we're getting further and further into this disease process is that is probably not the right avenue to take. And why is that? What we're finding is that these individuals have a different physiology than the typical ARDS patients that we see. So when the patient becomes hypoxic, they end up developing these bilateral infiltrates. Great. These bilateral infiltrates look very, very similar to ARDS. And we know ARDS, when it progresses, sometimes it progresses pretty quickly, and what those patients usually require is high levels of PEEP, and the best way for us to give patients PEEP is to put them on the ventilator. What we're realizing is that, yeah, it might look very, very similar to ARDS, but sometimes these individuals don't respond as well to PEEP, and you actually end up inducing more acute lung injury from the ventilator than you actually get benefit. And so I would caution the individuals that are saying 100%, every single person that's on greater than 6 liters needs to be intubated. I would move away from that and say that we have to start going back to our basics and really using clinical judgment. Is the patient eating a sandwich and on 6 liters? Well, maybe that patient shouldn't be intubated and we should continue to actually observe them. And so we try to give everyone some tools to kind of support what it is that they're doing and give them a mechanism to say, okay, this patient's getting in trouble, or okay, this patient's actually doing very well. So labeled as is, do I have to intubate this patient immediately? So one of the scores that we actually look at is something called a ROX index. So ROX index. And what they found, they've actually studied this and they've determined that individuals can have this score measured at 2 hours, 6 hours, and 12 hours, particularly after they're on high flow. And I would maybe extrapolate, we can't because there wasn't a study, but I suggest that maybe we could extrapolate even if they're not on high flow, that maybe we can be checking the score to kind of get an indication about which direction we're going. So the ROX score actually is defined as a ratio of oxygen saturation as measured by your pulse oximetry. So not necessarily an arterial blood gas, but pulse oximetry to FiO2 to respiratory rate. And it's been assessed as a predictor to need to intubate patients who are actually receiving high flow nasal cannula oxygen therapy. So again, remember, this really looked at high flow nasal cannula. You can't 100% extrapolate it, but it might be a tool to look at if you're really on the fence. This was actually a 2-year multi-center prospective observational cohort study, looked at 191 patients with pneumonia treated with high flow nasal cannula. In this particular study, 68 or 35.6% of patients required intubation. What they found was a ROX index that was measured at greater than 4.88 at 2 hours, 6 hours, and 12 hours after high flow nasal cannula initiation was consistently associated with a lower risk of intubation. And so again, you can measure it 2 hours, 6 hours, and 12 hours. If you were greater than 4.88 at those set time intervals, you have a very low risk for intubation. High risk for failure is a ROX of less than 2.85 at 2 hours, less than 3.47 at 6 hours, and less than 3.85 at 12 hours. So again, a tool, clinical judgment always trumps, but a tool to help us determine if these patients will actually require ventilation or not if they've been on high flow. So here's the bottom line. The ROX index potentially can be used to predict which patients will fail high flow nasal cannula and which may require expeditious intubation versus those who can be maintained on high flow nasal cannula. It is important to note that this study obviously did not look at COVID. So COVID patients act a little bit differently, but we're still looking for some tricks of the trade to help us decide who needs to be intubated and who doesn't need to be intubated. So helpful. So here is our protocol at OSU. And so this is really in an effort to avoid jumping straight to patients being intubated just because they appear to be hypoxic. We've already talked about the physiology. One of the things that I didn't mention about physiology on the last slide was that the thing that we can really look at is lung compliance. If you really want to get down to the bottom line, ARDS patients, they have very, very stiff lungs, which means that their lung compliance is very, very low. What they're finding with these patients with COVID is that they actually have better lung compliance than the ARDS patients. And they describe this as a bizarre hypoxemia that does not really correlate with their symptoms. We also know that mortality rates when you end up on the ventilator are greater than 50%. And again, like I've already mentioned, there's suspicion that this is secondary to us actually inducing lung injury on the ventilator. So if we can keep these patients off the ventilator, we may actually be doing them a service. The reason everybody has avoided using high flow nasal cannula and honestly non-invasive ventilation is the risk of aerosolization of viral particles. The risk of aerosolization really has been based on expert opinion from prior outbreaks. And yes, is there a risk? 100%. If individuals are on high flow nasal cannula though, what we found is that if you place a mask over their high flow nasal cannula, we can actually really reduce the risk of aerosolization. And so that, it doesn't completely take the risk out, but it does minimize the risk. And remember, the liters that you are pushing through the high flow nasal cannula actually plays a role too. So if you can get somebody, I don't know, maybe on 0.6 with 30 liters, that's really different than giving someone 0.6 on 60 liters. And so you have to kind of take that component into play too, to see how we can reduce the risk for all the individuals that are needing more oxygen support than we can actually give them on nasal cannula. And so I put a link on here that you guys should actually click on when you're reviewing this, because I think that it's a good slide set that we should refer to kind of justify physiologically why it is that we're doing what we're doing. I will tell you that my preference, and this is my personal preference, is that I would much rather use high flow nasal cannula over non-invasive ventilation. And the reason really is we've all walked into the room, 50% of the time those individuals don't have a tight seal. So the individuals that on non-invasive ventilation, so BiPAP or CPAP, half the time they don't have a good seal. Really hard to put a mask over somebody that's on BiPAP and CPAP, much easier to put a mask on a patient that is on high flow nasal cannula. The other reason that I prefer high flow nasal cannula over non-invasive ventilation is because we can actually do something called proning. And so we will talk about proning in the next set of slides, but essentially the concept behind proning is exactly what you guys see when you have individuals that have ARDS that are on the rotoprone bed in the ICU. We know that when we flip those patients on their belly, we can actually oxygenate them sometimes better. This applies to the patient that has COVID too, because if you look at the distribution of lungs that are injured, it almost appears as if it takes a peripheral route as well as a posterior route. So if you think about laying supine, what you're ending up doing is you have all of the weight of the chest and the heart that's kind of obstructing those posterior dependent areas and not enabling them to actually oxygenate as well. So when you flip the patient over onto their belly, you can actually oxygenate those posterior areas better. And so much easier to prone somebody on high flow nasal cannula or nasal cannula than it is on non-invasive ventilation, so like BiPAP or CPAP. So essentially our protocol at OSU says, hey, if they can do up to 6 liters on nasal cannula, 100%, let's do up to 6 liters on nasal cannula. If it looks like they're requiring a little bit more, reasonable to move that patient to the ICU if the ICU has a bed available. If the ICU doesn't have a bed available, also reasonable to consider bringing up the high flow nasal cannula, putting that individual on high flow nasal cannula and getting them to be on their belly at least 30 minutes, 3 times a day. it'd be ideal if you could get them longer. So most literature says that, hey, if you can get them to 16 hours, that would be fantastic. That might be a little bit tricky. So what we're suggesting is 30 minutes to 3 hours at a time, 3 times a day. So if they can do the max, 3 hours, 3 times a day, you can see that they can get 9 hours of proning. And we think that is going to help keep individuals off of the ventilator. So that's a little bit of our protocol. You guys can look through the protocol a little bit more closely. I know that the nurses have also been trained on proning, and they've got some protocols that they're following as well. So this was a study of high flow nasal cannula with prone position for COVID-19 and acute respiratory distress syndrome. Number one, this is actually currently being studied at Rush University. 29% of COVID-19 patients may develop acute respiratory distress syndrome, which is what their statistics actually show, in which the primary symptom is hypoxia that requires oxygen therapy. They presume, like we presume, that high flow nasal cannula has been proved to improve oxygenation to avoid intubation for hypoxic patients. So being studied at Rush right now, and they're using combination of high flow nasal cannula with prone positioning, and they're proposing that early use of prone positioning combined with high flow nasal cannula will improve oxygenation, reduce the need for intubation in COVID-19 moderate to severe ARDS. So again, we've kind of already talked about the physiology. What we're really saying is, hey, if their SATs are greater than 88%, but they're requiring 6 liters, maybe we should reposition to them prone position and trial them on high flow nasal cannula. And then depending on how they're tolerating it, we can use that in supplementation with the ROC score to say, hey, are they going to be able to be successful? Are they going to be able to avoid intubation, or are they not? And we use that ROC score to kind of give us a early indicator or kind of a red flag, like, hey, this might not really be working. Again, 100%, I'm asking you guys to use your clinical judgment above all. When you walk into the room, you guys are usually pretty good about telling, hey, this patient's either going to do well or they're not going to do well. So if they don't look like they're doing well, can I make some adjustments? Can I get them in the prone position? Can I adjust their high flow nasal cannula? Or listen, this isn't going to work. That patient probably needs to be intubated now. Well, there was also another small study of 20 non-intubated ARDS patients doing something similar to what Rush is actually trying to do. Their primary outcome was the rate of avoidance for intubation. And what they ended up finding was 11 to 20 out of 20, so that's 55% of patients avoided intubation. Of those, 8 of the patients had moderate ARDS and 3 had severe ARDS. We'll be honest, 9 of the 20, so remember 11 of the 20 avoided intubation, but 9 of the 20 required intubation, 2 had moderate ARDS, and 7 had severe ARDS. Out of all of that, 3 of those 9 actually ended up requiring ECMO. So what that tells me in conjunction is if we can catch these patients early before they progress from moderate ARDS, or whatever we're calling COVID ARDS now, before they get to severe, I think that there's a window. If we can start proning early and supplementing oxygen in the appropriate manner, there's a very good chance that we can avoid getting these patients on the ventilator. So this is, I don't know how many of you guys have seen this, but this is actually a picture of somebody with happy hypoxia. It's probably really hard for you to see this, but if you look really closely at that pulse ox number, that oxygen number says 54%. You're right, it says 54%. Patient's not intubated. If you really look closely at the screen, I am pretty sure that she is playing Candy Crush. And so just remember, clinical judgment trumps. If you walk into a room and they're standing 54%, but they're playing Candy Crush, maybe we should try something alternative instead of putting them on the ventilator. So there was a protocol that was described in Lancet. It's very, very similar to what we're talking about. Do they need oxygen? Yeah, they need oxygen. Should we try oxygen, CPAP, non-invasive inhalation? Do they need to be mechanically ventilated? Okay, if they don't do it. They put oxygen, CPAP, and non-invasive inhalation here. I would probably just say oxygen, high flow nasal cannula. Again, I'm not 100% convinced that BiPAP and CPAP is the way to go. Would I use it as a bridge? Yeah, sure, I'd use it as a bridge. But again, you also have these issues with PEEP. And I'm telling you that there's some type of lung physiology with these hypoxic COVID patients that don't respond as well to PEEP. But you know what we'll do? We'll walk in the room, we'll see bilateral infiltrates, and we'll be like, oh, it's ARDS, and we'll start cranking up the PEEP. The PEEP's still not making them oxygenate better, and now are we doing more damage than good? And so just kind of a slippery slope that we play, but it's kind of where we are right now. I put this slide in, kind of good, kind of not good. Essentially what this tells you, if you look at individuals that actually have a mask, like you can see without mask, 69% are trapped in a path of 1 meter, less than 1 meter, 31% greater than 1 meter. Okay, so we get it. If they don't have a mask on, it's going to travel further. So you see every time they do high flow nasal cannula or just oxygen therapy, they put a mask on, you can see the amount that it decreases in the room. So essentially I put this table in just to tell you, like, hey, if you're using high flow nasal cannula, particularly when you're getting up to 50 liters per minute or 60 liters per minute, if you can put a mask on the patient, it will dramatically reduce the length of particular spread, and it'll actually protect your providers. So, okay, we're trying to avoid intubation, but what if the patient actually needs to be intubated? So a couple things, I'm pretty sure, and I'm forgetting now, but I'm pretty sure this came out of the either ATS guidelines or the Society for Critical Care Medicine guidelines. We know that there's no direct evidence comparing the use of video laryngoscopy with direct laryngoscopy for intubation of patients with COVID. It's too soon. We know that SARS-CoV appears to be spread primarily by large respiratory droplets, but intubation will likely increase the number of small droplets. So when I say small droplets, I'm talking about less than 5 micrometers. When we get to less than 5 micrometers, that's when things get aerosolized. We know intubation can induce particles that are less than 5. And so we consider this an aerosolized generating procedure. So this increases the risk of transmission to healthcare workers. Knowing that, we know that it's risky. So we try to make sure that we're instilling techniques that actually reduces the number of attempts and limits the time that you're spending doing the procedure. So that being said, when we have to do endotracheal intubation on these patients, we do suggest using video-guided laryngoscopy over direct, because we think that it will improve first-time success rate and reduce the time that you are actually in the intubation process. And we also recommend that it is performed by the healthcare worker in the vicinity who has the most experienced airway management, so that we can minimize the number of attempts and risk of transmission. I mean, that's pretty common sense, and that's what we are following here at OSU. So if we have to intubate the patient, we obviously make it as safe as possible. And I was hoping that I could show you guys this video, but that does not look like it's something that's going to happen. But this is a video that is on New England Journal of Medicine. If you actually go through YouTube, you can actually find it. I think most of you guys have actually seen this too. And it is essentially a acrylic box that is placed over the patient during the intubation. It has 2 holes on both sides. So that you can actually intubate it and reduce the amount of particular spread during the intubation, so it doesn't get all of your face shield, your mask, your gown, your gloves, etc. So at OSU, we've gone to try to intubating patients using the acrylic box. If you don't have an acrylic box, we do recommend you kind of MacGyver it into where you can put a clear plastic sheet over the patient, so that you can reduce the amount of particular spread during the intubation, but actually still see what you're doing. Other things, if we are intubating the patient, they have to be intubated. We want to avoid N-acetylcysteine because it can cause bronchospasm, and it also increases the amount or the frequency of having to do an aerosolized procedure. You could consider normal saline nebulizer, BID, maybe. You should avoid oscillating positive expiratory pressure devices like the Acapella and the cough assist devices. And we also recommend that you avoid using CPT. Now, there are patients that maybe if they have cystic fibrosis that get affected by COVID, yeah, you don't really want to stop the CPT on them because they have home devices, but not something that we should just be generally applying to every single COVID patient. So again, here is just another journal article, and they are very, very abundant about COVID patients not having the typical, and you see it in quotes there, acute respiratory distress syndrome. This was actually out of the American Thoracic Society journals. You guys can read American Journal of Respiratory Care and Critical Medicine. What they found was the disassociation between relatively well-preserved lung mechanics and the severity of hypoxia was pretty impressive. Out of this, they essentially came out patients that are treated with continuous positive airway pressure or non-invasive ventilation can present with clinical signs of hypoxia, but we have to address these patients very carefully and case by case, not just to say, again, the happy hypoxic patient that you saw that was satting 54% and playing Candy Crush, that patient doesn't need to be intubated. So what they said as their conclusions from this journal was intubation should be prioritized to avoid excessive intrathoracic negative pressures and self-inflicted lung injury. High PEEP in a poorly recruitable lung tends to result in severe hemodynamic impairment and fluid retention. We know that when we give patients high PEEP, we oftentimes see hemodynamic alterations. They become hypotensive, they can start retaining fluid. And if the physiology is different in the COVID patients, maybe we need to be cautious about using it in these patients. They also found that prone positioning of patients with high compliance, which is what these patients are, result in a pretty good result. And so what they actually recommend is proning these patients. We've already talked about this in the wake patient. We would do the same thing in the ventilated patient about proning them early so that we can get more bang for our buck. Does this mean that a COVID patient cannot develop ARDS? Absolutely not. You know, I spent a lot of time telling you guys, hey, the physiology for COVID is a little bit different than the physiology for ARDS patients. But it does not mean, I mean, we know this. Everybody can develop ARDS. Patients who are septic can develop ARDS. Patients who have pancreatitis can develop ARDS. I mean, the number of things that can cause ARDS development is huge. The list is never ending. And so I'm not saying that COVID patients cannot develop ARDS. I'm asking you to use your clinical judgment. What does their compliance look like? Have you talked to respiratory therapy? Have you talked to pulmonary critical care? Does it seem like they've got good compliance? Does it seem they have compliance like an ARDS patient? If they have compliance like an ARDS patient, we treat them like an ARDS patient. And so this is just for your brief review. We know that ARDS, here's the definition. It's usually acute. They've got bilateral opacities detected on chest radiograph. They've got a PaO2 to FiO2 ratio of less than 300. And then you guys remember the categories under ARDS: mild, moderate, severe. Severe being a PaO2 of FiO2 less than 100. And then it also, I like this slide because it shows you what the mortality is. You know, when patients have a PaO2 of FiO2 ratio of less than 100, their mortality right off the get-go is 45%. So not a shocker that these patients who are on the ventilator with COVID have greater than a 50% mortality rate. So kind of falls in line with ARDS, which is why I think everybody was like, oh, it's ARDS, it's ARDS, ARDS. Yes, it can be, but you have to be careful about what type of ARDS. Is it COVID ARDS with good compliance, or is it straight up ARDS with poor compliance? So here's just kind of a do's and don'ts as far as the Society of Critical Care Medicine guidelines go. And I'm not going to read every single component of this. I mean, you guys know most of this. One of the things that have changed recently in the SCCM guidelines is we really try to titrate our sedatives and analgesics to ventilator synchrony, allowing for a deeper RAS. When we're doing a RAS, a lot of times we also use it in conjunction with paralytics. If we're using paralytics, we want their BIS score to be 40 to 60. They recommend using fentanyl and propofol with Versed as a second-line agent. I'm sure this is because of all the things that we've seen about Versed and Versed hangover. We know that propofol is easy on, easy off. One of the things that I also like to point out on this is, like, if you look at both COVID-19 with moderate to severe ARDS and rescue/adjunctive therapy, we start with NMBA boluses. So those are your neuromuscular blocking agents, so your paralytics, essentially. So we use Nimbex, and so the question is reasonable to just give Nimbex boluses as opposed to just going to an immediate infusion? And why? Why do we do that? Because we try to get ventilator synchrony with doing the least amount of harm that we possibly can. We know, and I know the literature is sometimes a little bit confusing about this, but we know that when we have patients on steroids and we have patients on paralytics, a lot of times when those patients come off the ventilator, they end up developing critical illness myopathy or critical illness polyneuropathy. And so that's why you see under this COVID-19 with moderate to severe ARDS, you see NMBA boluses to facilitate ventilation targets. You don't see them immediately go to a NMBA drip. Now, does that mean you're not going to have to go to a drip? Not necessarily. Go down 3 slides. hey, we might have to do an infusion for 24 hours while we're proning. The other thing that they talk about is doing traditional recruitment maneuvers, which is a little bit different than doing what they call stair-step maneuvers. And again, if we're starting to do these traditional recruitment maneuvers, this is probably a good time for you to ask pulmonology to kind of help with this piece so that we don't inducing more damage than we do benefit, because we really have to make sure we know where the compliance is. But I thought this was a pretty good slide. I think that things are going to change pretty quickly. You know, we see in that middle slide again, we talk about antivirals, chloroquine, and anti-IL-6 agents, which we'll talk quite a bit about in the next lecture. But the jury is still so far out on this, because one day it's the greatest thing, the next day it's probably killing people. And so it's really important for us to be reading the literature and see how they're getting their information and whether it was accurately assessed or whether there's a lot of fluff in there that we need to dig through. So septic shock in COVID-19, can they develop septic shock? Yes. Remember, we talked about that's that 5% of the patients that end up developing sepsis from COVID that will end up developing septic shock. So there are just some basic parameters. And again, this was from the CCM guidelines. Number one, conservative fluid strategies, not liberal. We usually like to keep these individuals a little bit on the dry side because it'll improve their oxygenation. For the acute resuscitation, obviously, this is no different than what we do for every septic patient. We suggest crystalloids over colloids. Same as we do for sepsis, we suggest using norepinephrine as the first-line vasoactive agent. And then if norepinephrine is not available for some reason, we suggest using either vasopressin or epinephrine as the first-line vasoactive agent. So good. Some things that I will tell you is, remember, epinephrine can prolong your lactic acidosis. And so remember, if that's what you're reaching for first and your patients have an elevated lactate, you may prolong the clearance of that lactate. And so you may kind of stay in a little bit of an acidotic state. So I would definitely use norepinephrine first, probably use vasopressin in conjunction. Remember, vasopressin's claim to fame is that it works in acidotic state. And so that is probably a good pressor to reach for second. And remember, we always kind of go down that route of a high lactate means that they're hypovolemic. Yes, we use that to guide our fluid resuscitation, but remember, you may have a high lactate just based off bacteremia or some level of anaerobic glycolysis that we are seeing that persistently elevated lactate. So yes, we can use it as a guide, but remember, you want to use more of a conserved fluid strategy on these individuals than you do a liberal fluid strategy. Vasopressin, remember, you can see the digital ischemia. Epinephrine, we've already kind of talked about. Excess lactate production may be consideration for not using epinephrine. And so very shortly, not all patients will get worse. I know we just talked about, okay, the patient's going to get respiratory failure. They're going to become hypoxic. They may end up on the ventilator. Maybe they'll end up on high flow nasal cannula. Oh, great. Maybe some of them are going to develop septic shock. But not all patients will get worse. Some will actually get better. So what do we do if, this patient's great, now we want to discharge a COVID positive patient? Do we have to wait 14 days for them to be discharged? No. This is very similar to discharging a PUI. However, if you do have a COVID positive patient, they look great. When you walk in the room, their hemodynamics look good. The two things that I will tell you to adhere to is, number one, have they resolved their fever for greater than 48 hours without antipyretics? So without giving them a whole ton of Tylenol, have they resolved their fever? And do they really have improvement in their illness signs and symptoms? So is their cough better? Which, remember, it may not be better for about 4 weeks, but is it not causing them to have these transient drops in their O2 saturation? Do they feel better? Is their shortness of breath improved? And what are their oxygen requirements? Have you gotten them off oxygen? So other things that you can look at the consideration for the following labs on discharge to compare to admission, because it might give you a little bit more confidence in your discharge plan. Looking at their LFTs, looking at their CBC, their ferritin, their CRP, LDH, CK, did they all lower? And again, have they been afebrile for 48 hours? On top of that, You also want to make sure that you look at your basic discharge planning. You want to make sure you've got a contact number for the patient, and you want to make sure that you can call somebody else if for some reason they're not answering the phone. You want to ensure that they've got a private room and ability to adhere to home isolation instructions. You will see that this becomes a little bit tricky for us because we are kind of the safety net for the city. So we take care of a lot of the homeless population. So where are you sending them? Are you sending them back to John 3:16? Are you sending them back to Salvation Army? Are they going to have to go in and out of Quick Trip 6 times a day so that they can get their fluids, so they can get something to eat? That might not be the best option. So even the individuals who do have a residence to go to, again, we kind of talked about this in the first lecture. Are there 5 people in a single bedroom, single bathroom house? If that's the case, that might not be our best option. You want to make sure that they can do their ADLs with a degree of support at home. You want to confirm that they've got resources, social support, so that they can actually get food, so they're not, again, going to the Quick Trip or going to resource and infecting every single person and piece of furniture they actually touch. Do they have the DME they need? If they're leaving the hospital, you want to make sure that you provide them with a surgical mask, particularly when someone's picking them up. You don't want to infect that person while they're actually being transported home. What we've suggested, we've got very few resources to get these patients to where they need to be unless they've got a ride. Our social work team has been super helpful on looking for alternatives if they can't actually go home with someone. There is a bus route here in Tulsa that has agreed to take up to 10 patients a day. And so that number hits 10 very, very quickly. But that's something that we can look at. There are some cab companies that may or may not be able to transport these patients. And then honestly, some of these patients need to be transported by ambulance, but this is something that you want to think of before you're hitting that discharge button to make sure how are they going to get there and where they're going, is that the right place for them? The other thing that I'm strongly recommending is that you provide the primary care provider with a warm handoff. And so what does warm handoff mean? That means actually pick up the phone and talk to the provider that's actually going to be taking care of them, so they know what to expect, they know kind of what the recommendations are in regards to their follow-up. One thing that we set up here at OSU is really a really easy way to get in touch with Melissa Cox, who is agreeing to take Cortex in regards to patients that she needs to follow up 24 hours a day, 7 days a week. So you text her the name, you text her the phone number and the date of birth, and she will be able to access it, and she'll be able to get a virtual visit through DoxyMe for those patients. This becomes really important to us too for another reason, is remember these patients, when they recover, they become eligible to donate plasma. And donating plasma right now is a huge thing. It's one of the therapies that we're very, very hopeful will help some of our patients that are either severely or critically ill. One patient who has recovered can donate up to 3 units of plasma. So you think about that, you get 10 patients that are willing to donate, you might actually be able to help 30 patients. Dr. Derby, Dr. Connell, and Melissa Cox have played a huge role in facilitating this, and we have actually had some pretty good success in getting these patients enrolled. And so really for these COVID positive patients, what I'm recommending right now is making sure that we have a follow-up visit, because we know we can ensure that they can have a virtual visit. And we know that we can ensure on getting them the pathway to donate plasma. And so those are 2 big things. And so I would strongly recommend that we're utilizing that resource in this time where everything is just a little bit uncertain and we're not sure all of these individuals will be able to get the timeliness of their care through a virtual mechanism unless we actually support it for them. So just a couple other final points. What about viral shedding and infectivity after discharge? There was one study of 21 patients with mild illness who had no hypoxia. 90% had repeated negative viral RNA tests on nasopharyngeal swabs by 10 days after the onset of symptoms. Tests, however, were positive for longer in patients with more severe illness. There was another study of 137 patients who survived COVID-19, and the median duration of viral RNA shedding from oropharyngeal swabs was 20 days, with a range of 8 to 37 days. And so there are a lot of studies that are looking at this. They really typically look at viral RNA to determine rates of infectivity, but we know this is flawed because the presence does not mean that you can automatically infect patients. And we just know that the duration of viral shedding is really variable depending on the severity of illness. It's also interesting too, because there are individuals, and you'll read about this in the World Health Organization, you'll see trials that are coming out of Wuhan that say, oh my gosh, these patients essentially tested negative this day, and then in 5 days they tested positive, and they'll start saying, oh, they're reinfected. The patient's absolutely asymptomatic. We know that the viral the sensitivity for these tests is about 70%. That's why we do 2. And so maybe that first test that they did was really a false negative, and the second test was, hey, there's still indicators of virus. It's so hard to tell how long these people are going to be infected for, and I just don't think we know the answer to that. So we still kind of adhere to the 3 days since you've had a fever without taking fever-reducing medications, and 7 days since your first symptom, until they can really come out of quarantine, but they still really need to maintain social distancing subsequent to that. And so again, this is another slide which I think is interesting. Can I be reinfected? So okay, now you definitively had COVID. Am I going to get COVID again? There was a study on recovered COVID-19 patients in southern China, a city that I can't pronounce very well, Shenzhen. Almost 15% of patients tested positive that they were discharged. They were confirmed via PCR. The 38 patients, again, displayed almost no symptoms during this period, and they were not symptomatic at the time of their second positive test. Again, kind of just goes back to what we were saying. But now, can I be reinfected? There was a study that looked at, I'm forgetting the type of monkey. Oh yeah, I don't know how to say this either, mac monkeys. And they said that the macaque monkeys absolutely cannot be reinfected. I don't think anybody really knows the answer or not, but they found that the antibodies in these rhesus monkeys kept primates that are recovered from COVID-19 from being infected again upon exposure to the virus. So again, that's a preliminary study. It was studied by Chinese researchers. That study was not peer reviewed, but it did find those antibodies in these rhesus monkeys kept primates protected. So they've been infected once, but they had antibodies to protect themselves. I think it's something that's going to kind of play itself out as we go. And I'm hoping that this next video plays, but I'm pretty sure that it's not going to. So I don't think I'll be able to show this to you, but I strongly encourage you guys to Google this or YouTube this too. It is a skit from a very popular, I guess you could call it sitcom. I think back when I was actually in medical school. It's called Scrubs, and it just shows, it's very similar to the movie Contagion. It shows how quickly these individuals can reinfect others. So it starts by a mom blowing her kid's nose and then dropping the tissue paper and then turning around to shake somebody's hand, and you just follow the green hand and see how quickly this propagates. I think this gal over here in the red is being discharged from maybe getting a bypass surgery, and this guy over here in the gray hoodie comes over to shake her hand. Well, he had picked up some tissue or something, and she shakes his hand and then ends up touching her face, and now you can see how quickly everything is spread. And so this is why we're emphasizing social distancing. Just be mindful of how close you're coming in proximity to individuals and what you're touching, who you're touching, how often have you shaken your hands. Probably a good lesson for us to follow, and something that you need to strongly emphasize to your patients. Just because you're getting discharged from the hospital does not mean that your work is done. And that will conclude section 2 of our 3-set series, and we will be with section 3 here shortly.